You might remember a few of them. There was a mental health event called Erasing the Stigma, and that was, I think, in February of 2013. That kind of kicked off this idea. There was another project called Battlefield Breakthroughs, which looked at medical innovations that were born on the battlefield. Last fall, Lauren began reporting for the broken hip. And since then, the series, since the series launched this spring, it's had a remarkable impact. From hospitals and social service groups across North Texas to public media stations around the state and across the country, to attention from national organizations like NPR and Next Avenue, where the series was also distributed. We heard a series of riveting radio reports, from the heart-wrenching story of a woman who died while we were putting the series together, to a healthcare executive who had firsthand experience with the issue when his dad broke a hip, and to a woman who's a bundle of energy and bounced back after breaking her femur. There's also a cutting-edge website that we put together that included a number of innovative elements. You can find it at kera.org/thebrokenhip. Feel free, by the way, to tweet along at #thebrokenhip. Send in any questions you have, and we'll try to address them during the Q&A portion of the program. Thanks again for coming out tonight, and I'll turn this over to our expert, ladies and gentlemen, Lauren Silverman.
Thank you guys all so much for coming. I really appreciate it. I know how exhausting it can be at the end of a day to come out to another event. So let me just pull up my presentation. I usually am behind a microphone that I'm holding for someone, so it's a little unnerving. But I do this to people every day. So when an older person falls and breaks a hip, it's a moment that changes everything. And not just for that patient, but also for their families and for their friends. Falls are the leading cause of injury death for older Americans. 1 out of every 5 people who falls and breaks a hip actually dies within a year. So there's also what happens though for those who do survive. It means a big life change, both in your home situation, your family situation, caregiving situation. And I don't want to overwhelm you entirely with numbers, but there are a few that I want to point out. One is $30 billion, and that's the amount of money that it costs our healthcare system every year for falls alone in the US. Each year, about 250,000 people have a hip fracture. So after finding all these numbers at KERA, we wanted to come up with a series that would be able to look a little bit deeper into what was behind them. And what we wanted to do was not only approach this as a radio story, but also as video, photos, and infographics. So we wanted to tell the stories of people who've gone through this experience, and also give you a sort of surround sound experience that would go a little bit deeper than a typical radio story. So what we did was also break it up into chapters, and that allowed us to dive deeper into, as you can see, 8 chapters of the issue. So we didn't have to try and cram it all into a 3-minute piece, which is what a lot of times you have to do when you're working in radio. Now, in each chapter, like I mentioned, we have radio as well as video for some of them. And one example of that is a video we did with UT Arlington focusing on fall prevention, that they have a class that's ongoing. So let me just play a little bit of that for you. Oops, sorry. Hold on 1 second. There we go.
So what we do is try to look at ways to decrease fall risk and improve senior fitness in older adults. At the end of the day, we want to know what types of interventions work best for individuals with certain specific physiological deficiencies, things like bone mineral density. As a factor in fall risk, obviously, if you want to fall, you want to be resilient to that fall.
I'm Joyce Powell from Arlington, Texas.
I'm Tom Powell from Arlington, Texas. We've lived here for about 52 years. Okay.
It stays with you once you've gone through something. The memory of it sort of keeps taking away at you, and you don't risk things like you used to.
The greatest predictor for a future fall is a previous fall. So we start to restrict the activities that we perform, and that's no different in aging. You know, as we age, if we were walking out on an icy sidewalk, we decide we're not going to walk out on icy sidewalks anymore, and that's a very appropriate selection. But if we don't replace that, if we don't find other activities to engage in that are appropriate or age appropriate, then we see a decline of strength, neurological, eventually cardiovascular, pulmonary, skeletal, all these systems start to decline, and eventually that has a very compounding effect. In daily life, when we see seniors that fall, it's usually during multitasking. And so what we'll do in here is we have the opportunity to recreate that. So we can either type in loud noises, city sounds, or music. We can type in visual distractors on the screen, or we can even have them take like an IQ type test or a distracted type test on the screen as they're trying to maintain their postural control, potentially with the walls moving and everything kind of moving in concert. We line them up appropriately on the sports plate. If they start to lean back, the walls come towards them, or if they lean forward, the walls move away. And that gives them that faulty feedback to their visual information and forces them to maintain their balance or maintain that kind of stable, upright stance.
Don't worry, I won't make any of you try and stand on that and while taking an IQ test. I didn't have to do that, so I was lucky. I spent several months identifying stories to tell from people, patients, families, doctors. There were so many of them, and at some point I wanted to move beyond talking about the problem of the broken hip and some of the sad statistics that go along with it, to looking more at prevention and more at innovation in how we can address this issue, which led me to the movement of aging in place as one example to highlight of a way that people who fracture a hip or have a fall are no longer necessarily going to end up automatically in a nursing home or an assisted living. There can sometimes be the option of remodeling, making adjustments at the home so that you can stay and live there. So this is the story of Courtney Sands, who lives here in Dallas, and 90% of people over 65 say they want to stay in their homes as long as possible. She is no exception. She wants to stay in her home. She fell, slipped on ice, broke her hip, and refused to leave her home. So Adam Mandel, who's featured in this video, went in and made some adjustments so that that was actually possible.
One of the biggest issues that we face is getting in and out of bathrooms. In most homes, particularly older homes, they have 24-inch doors to get into the bathrooms. A walker is wired, so they cannot leave their walker. They cannot bring the walker into the bathroom. So what happens to a lot of my clients is they leave their walker outside of the bathroom, so they can't get through the door, and that's when the fall happens, because they're grabbing on the counter, grabbing on the sink, something happens and they fall down. So one of the things we did is we widened this bathroom door. Now it's wide enough that any walker can get in, and any wheelchair can get in if it comes to point where she needs to use that. All these falls and slips, the majority of it take place in the bathtub or the shower, because obviously it's a wet area, it's really slippery. A lot of people will grab on whatever they can, like a shower rod or a towel rack, and those obviously aren't anchored very well. So I want to put in really good grab bars. Getting in and out of the house is really important, obviously, and not just for everyday activities, but I also like to look at in case of emergencies. I want to make sure they have an exit that can be out by themselves. I like using garages for ramps because they're protected from the weather. So if we get outside in front of the house, if there's an ice storm, if it's raining, whatever kind of weather it is that's happening, it makes it a lot more dangerous and a lot less convenient. A lot of times I'll go in situations where, the church is out there with a neighbor, and they'll have like a 5-foot ramp here, and it's literally, this kind of angle. And I joke to say it's sort of like an evil people. Driving wheelchair jump over 20 buses is an appropriate ramp, but for safely getting in and out of the house in a wheelchair or walker, we definitely need to have this slope. And let's face it, there's way more people than there are retirement communities, so a vast majority of people really are going to stay home. As our population's aging, this business is just going to get bigger and bigger, and it's going to be more demand.
And we also created an infographic to go along with that radio story and that video, as well as photos. You can't see it here, but if you go online to the KERA Breakthroughs, the Broken Hip Project, you can see the different areas as you highlight them with tips for how to help fall-proof your home. So I hope this gives you just a very quick glimpse into the Broken Hip Project. It's all up online at kera.org /the broken hip, projects.kera.org /the broken hip. And we're going to transition now into the panel discussion and then go to comments and questions. Please hashtag for anyone who's watching the Broken Hip, and I can't wait to hear your thoughts. So as we do that, I'm going to invite our panelists up. We have Dr. Alan Jones from Baylor. He's an orthopedic surgeon at Baylor. He's also featured in the project. Thank you so much for coming up. And then we have Janet Mariani, who's worked in senior and retirement living communities across Dallas. Right now she's with Traditions Senior Living, and her mother was featured in the first chapter of The Broken Hip. She fell and broke her hip and died several months later when we were working on the project. And then we also have Cheryl Akers, who is a nurse and a geriatric care manager. We'll explain what that is in a moment for people who aren't familiar with the jargon. All right. These are a little bit longer.
Let's do a little demonstration.
So first to get things going, Dr. Jones, what is it that makes a fall such a serious event for an elder person?
Well, the biggest issue is that the biggest issue for a fall in an older person is the risk of injury, and particularly fractures. And so the population of patients who are older also have a very high incidence of osteoporosis or weakening of your bones. And so a fall that, when you're 40 years old or 20 years old or even 50 years old may not injure you, just a fall from standing can result in a truly life-threatening fracture of your hip, your pelvis, or something else.
So before we move on, let's get to what are some of the things, the advice that you give to patients who you're concerned about, who are at that age where they may have some osteoporosis and they may be at a phase where a fall could be something that's actually deadly.
Well, first thing is that osteoporosis is a disease that can be treated, and so and prevented to some extent. And so the most important thing early on, as soon as you're, particularly for women, as you turn 50, all the things you need to start doing, one of them is to get a baseline bone density test to see where you are, and then if needed, either a follow-up test or even treatment if you have osteopenia, which is the same disease but not a severe progression for osteoporosis. Other things are things that help, you've already mentioned, decreasing your risk of falling at home, and there's lots of things to do. And then other things like things that can cause falls, alcohol, other things that, like tell my patients, risk-taking procedures, like things like getting on the ladders and climbing up on things. It's tempting to do, that's something you want to get off the top shelf or out of the attic. It's something you need to think about because it's the consequences can be very impactful and even fatal.
Now, for a lot of people, it is possible, and a lot of people do recover from fractures and broken hips, but they may not be able to do all of the things that they were able to do before, getting around the house or driving or some of those types of activities that were just normal. Cheryl, you're a geriatric care manager. what role do you play in helping people who are at that stage of maybe recovering from a hip fracture?
As a geriatric care manager, hopefully we're called in before the hip fracture occurs. A lot of times as a care manager, we try to facilitate a plan long-term for what type of living conditions are you going to be happiest in. Most everybody says, I'm staying at home, I'm going out feet first, and that's the end of the story. So we try to figure out what some of the issues are, potential issues, because when you've been living in your own home for an extended period of time, it's the old, you can't see the forest for the trees. They don't realize that throw rug really should be thrown out, or they don't realize that there's a trip hazard with the stairs and there's not a good safety grab bar in the bathroom or whatever. So what we do as geriatric care managers, and many of my colleagues are here tonight, we actually sponsored some of the event. And we try to look at the financial, the physical, the social, the psychological issues of aging and how things get impacted as we age, because obviously none of us are getting out of here alive, not necessarily in this room tonight, but the thing is, we all are going to die eventually. And we all want to die the best death, and everybody says, well, just shoot me, I'll just have a heart attack, fall over, and die. Well, I'm sorry, we'll save you. Medicine is getting much better. And so how do we plan for that what if? What if you should fall? Or what if you should have a heart attack? Or what if you should have a stroke? What do you do? And so as geriatric care managers, we educate, facilitate, instruct, and primarily advocate for that senior or aging person to say, yes, your kids may tell you have to go to a nursing home, but that may not necessarily be the case. There are lots of options. Here's what some of them look like for today, next week, next month, next year, and how to pay for them.
And we'll get to some of those options. Janet, your mother fell and had a hip fracture, and it's important to know that you have done many of these things to try and prevent this from happening, but sometimes you just can't prevent this from happening. It just happens. So what can you do as a daughter, as a caregiver, to try and, if not prevent it, to make it work as well as possible?
When I think about my mother and how she broke her upper leg, almost the hip, my mother did everything a daughter prays she'll never do. She didn't wear her pendant on the hook. She didn't have her bedroom light on like she always does. She turned off her bathroom light before she got disoriented and fell over the bedroom chair. And then she laid on the floor all night because she didn't want to call me and wake me up. I mean, everything we went over, or call it front desk, she just, but, you do everything you can to falls happen. They just do. And, but I agree totally that, you can practice and look at your surroundings and make sure the environment is as perfect and as straight as can be. Very low mat on the carpet and nothing there to trip over, the proper shoes. A big thing for me is really watching alcohol intake, because now you have mostly drug interactions to deal with, let alone maybe too much to drink, and they just don't realize they've had that much. All kinds of things could slip or fall.
Yeah. And a lot of those slips and falls today, if you break or fracture your hip, they're repaired usually with surgery. And we tried to highlight in the series also how far technology has come in terms of treating hip fractures and broken hips, from using ivory and rubber, my favorite, even glass I read about, to today mostly titanium and some other metal alloys. So Dr. Jones, tell us a little bit about what you expect the future of hip fracture repair to look like.
Well, I think one of the things that's changed over the last 5 to 10 years is our understanding of those patients who break their hip right next to the joint, where we used to try and repair them with screws and things that very commonly didn't work out. Many times we're moving towards a replacement, and sometimes even a total hip replacement, where it's basically the same sort of operation you do for arthritis. We find that those patients, we do one operation, they're up and going, and gives them the best chance of having a return to their function and maintaining their independence.
So instead of stapling and screwing, you're actually just putting a whole new
Right, and we still do that, and what's different in the repair process is that we do it through smaller incisions with better designed techniques and implants that really make it where you can put weight on it and walk on it right away. It doesn't feel great, but it's, the reality is the surgery is not the biggest deal of breaking your hip. That's not where all the mortality comes from.
So where does it come from?
My personal feeling is that for many patients who are older, many times with a lot of medical illnesses, they're sort of just barely in balance. The hip fracture tends to then tip one or more of those issues out of just enough out of balance for you, and then instead of having a steady state, you have a decline. Sometimes it's their cognitive function, and so you get less, more confusion and things. Sometimes it's their medical issues, whether it's heart failure or whatever. I think in the introduction, one of the things that's a real problem is we ask our patients to walk and do stuff to get better, but they're deathly afraid of falling, and they're many of them are unwilling to do that because they see the risk, and it is the risk.
Yeah, one of the things that really stood out in reporting this was how serious the fear of falling was in terms of preventing recovery. Just like if you don't use your muscles, they obviously will decline and lead to more falls. But it's scary to get back up. If you've ever fallen off a bike, it's that same feeling. Now, the cost of a broken hip is another whole series that we could do to explain. It can range from $10,000 to $100,000. Your insurance gets in play. And then, as you said, the surgery isn't the only cost or the only aspect. There's also the cost of care afterwards. Now, Cheryl, how do you find your clients managing the cost of care after something like this happens? How are they paying for it?
Well, during the acute care phase where you're in the hospital and potentially going to either rehab, acute rehab or skilled nursing rehab, obviously that's usually covered by some type of insurance, and hopefully they've got a pretty good insurance plan. And then they may come home with home health, again, mostly covered by insurance. But then because of the impact of the hip, recovery, they may not be doing as well. They may not be as mobile. They may not be able to access the bathroom, and they may not be able to afford a widening of the doorway to access the walker. As Adam clearly stated, the walkers usually left out in the hallway. I always thought people get two walkers, put one inside and one outside. If you can't pay for the doorways, you could pay for a second walker. But they don't realize, most people don't realize what insurance does or does not cover. I worked with health insurance board for years, and nobody ever knew what their insurance covered. And most people think Medicare is going to cover that long-term care, whether it's care in the home or whether it's care long-term after the rehab process in a nursing home or even assisted living, and they're all going, well, that's Obamacare. No, it's always been that way. And so it's a process of education. And obviously, it's kind of after the fact they cannot purchase long-term care insurance. And there may be benefits if they're a veteran or if the spouse or widow of a veteran. But again, that's a process and that doesn't cover everything. And so, people say, well, I don't want to spend that money. Well, the rainy day, it's here, it's pouring. Get the umbrella, you're going to have to start paying for the care. And everybody's shocked that, assisted living will start at $3,000 a month up to who knows what, depending on all the needs. Nursing home care, $5,000, $6,000, $7,000 a month. If you have 24-hour care in the home, $6,000, $10,000 a month. So everybody's going. And I'm going to put them in a heart failure, but that's the reality of it. And so they have to try to figure out how they can piecemeal stuff together so they end up, well, I call my neighbor and she'd come and help for 2 hours, and well, my daughter works and she'd come home after work and cook some. And so you get all this higgledy-piggledy stuff going on, and everything's disjointed, and it's kind of really frightening, which again puts them at more risk because they're not cooking, they're not eating as well. They don't want, it's very difficult.
Well, that sort of transitions. I want to open up to questions and comments about what you're saying about challenges with figuring out what insurance covers and the whole changes within the healthcare system. I think we're lucky enough to have Dr. Dan McCoy here from Blue Cross Blue Shield, who's also featured in the series with his father. I'm curious, Dr. McCoy, maybe Jeff can come around. He's going to have the microphone. So anyone who has questions, raise your hand or comments. and he will try and get to you. But first, Dr. McCoy, what do you think changes within the healthcare system, what effect do you think those are going to have on how we care for elderly patients who fall and fracture the hip? How might that change, and how would you like to see it change?
I think the most important thing that needs to change is the connectivity. I heard an interesting word on stage, and you said it's fractured. Well, I mentioned this on our before, it's a fractured hip, and it's kind of a fractured system.
It is.
So what happens is you take a fragile individual who is somewhat tipsy, as you said, about medicines, about being stable, living at home, maybe bordering the edge, that is serious and with a broken hip. When they enter a system that's not necessarily connected, it's not easy to manage, it's not easy to manipulate, it's foreign to them, they're in a strange environment, their family doesn't know how to deal with those issues as well. And you're set up for that. So to me, when I look forward to how we transform our healthcare system, it's to build connectivity and seeing the state of care. So when someone gets in the hospital, there's something happening in the shift. You know that the right test is being ordered, the surgery's getting done at the right time. I'm not a big surgeon, but I think you'll agree with me that getting that patient treated quickly and urgently in the system and getting them good outpatient care that's managed with the primary care physicians so that they get the comorbid factors managed as well as their hip is those are the kind of things that have to happen to get success. So when we manage our healthcare system, that's what I would want to be totally say, that we're moving toward kind of connecting everyone around the management of the key issue.
Thank you. Are there other questions or comments?
I'm a journey manager.
We'll go to you first and then you're
I'm a journey
Tell me your
manager.
name and
I'm Kay Paggy. And on my website, I have reviewed a book called My Mother's Hip, which is not really new, maybe 5 or 6 years old. And this woman did extensive research on what happens when an old person breaks the hip. First thing that she noted is that in the United States, 25% of hip fractures return to their status of what they were pre-fracture. In Europe, that figure is 76%. Second question is, according to her research, women who take estrogen or who use hormone replacement therapy, as soon as they stop taking it, the effects are as if she had never taken it. So it doesn't stay with you.
Dr. Jones, can you address either the first thing, which is what is different about if that figure is true, and I can't verify right now, but what happens differently in other healthcare systems or with care and surgery that might make a survival rate higher?
Well, I've actually spent some time during my training practicing in the UK, and so during that time I've had to easily 300 fractures. So, one, their population is our population in a few years, so it's already older and osteoporotic. Their system is very different though, and the expectation that everybody's going to get everything and really do the maximum to save every life is not the expectation. So many patients in their system die in the hospital that wouldn't die in ours just because it's just the way that things are. They also have a lot more, to his point, the system is a lot more organized sort of around the central problem, because they've been dealing with the problem a little bit longer than we have. And so there's the prevention, there's the aftercare, it's a lot more organized, and there's not it's not a finite end of things. And there's also a lot more community and other resources. So it's a completely different system, but I have to say though, the patient's expectations, both as part of recovery and living and dying, are much different.
Interesting. Well, let's go on to one more question.
One things about, at least the part of England that I was in, there's no such thing as ramps and stuff like that, so most of the patients were relatively fit because every single day they got exercise. And so the history of a 90-year-old falling off their bicycle happened all the time.
There you go. All right.
Hi, I'm Barb Glass, and you mentioned about the difference between the way we take care of older people here versus the UK. Do you foresee, I mean, I see our insurance system moving more toward the model where they're maybe going to not fix things. You know, has there ever been a broken hip where an insurance company has just flat refused to fix it?
Well, not.
Or, I mean, do you see some squeezing of the benefits of this?
Well, the reality is because hip fractures are emergencies, and as was already pointed out, doing the surgery sooner rather than later, unless there's some good reason to wait, is an advantage for the patient. So we don't really ask the insurance companies for permission. Has there ever been a hip fracture or surgery or hospitalization that wasn't paid for? Oh, absolutely. And, you know, lots of them. And so even in Dallas, we have a fair number of undocumented aliens and with no healthcare coverage whatsoever. So that's us as a community paying for it, but it still doesn't mean that we don't take care of them.
Yes, and Julie from Baylor, she's representing all the people who are tuning in via Twitter or Wallstream.
Yes, we have a question on Twitter about doctors prescribing exercise before hip metatarsal abrasive, and if that's maybe a trend or if that could be something that happens in the future.
Now, first I'll just ask, did that happen with your mother? Was exercise prescribed to her, Janet?
Well, absolutely, because my mother lived in a fabulous community. And she had exercise all the time available. Now, whether she would do it, that would be, and she would just work that very well.
And
She was a walker too.
Oh,
She loved to walk.
on the ramps or on stairs?
You know, up and down, whatever, hallways and streets.
Do you prescribe exercise?
Well, remember, I see most
After
patients,
the
it's after,
surgery.
I'm just telling them about closing the barn door after the horses go.
Yeah.
So, but still, exercise is very important. And so I do think it's a trend among our physicians, at least within our Baylor organization, and it's part of the things we do as part of adult health care. You know, as you get older, you need your colonoscopy, you need your mammogram, you need your bone density test, and then you also need to know about falls and exercise. And exercise is part of bone health. And you need something around 45 minutes of weight-bearing exercise a week. That's not a lot. It doesn't mean you have to, you know, do high-intensity, you know, running or anything like that. Just walking and getting some exercise. As we saw in that video, practicing your balance, very, very important.
I prescribe exercise.
Good.
Yeah, as a care manager, I mean, my goal is to educate my clients before they run into trouble. And I tell them about exercise and why and how and explain all the ins and outs because, like, I'd rather you do this now than have to do it in a rehab setting. You pick. And they go, oh, okay.
One of the things I always suggest too is older people tend to get up too fast. They don't really stop and think, I'm going to get up. They just get up and go. And I have a very dear friend who just had a few falls and she fell back and actually broke her neck now. And it's because she gets up too fast. And I think that's the one thing I think about, even in the morning when I get out of bed, is just kind of sit there for a little bit. Just kind of, don't just jump out of bed, get up, get stabilized, hold on to something, stand up. I'm a big proponent of teaching that. To really stop.
But unfortunately, with bladder, sometimes you gotta move fast. Let's get down to basics.
Remember, I got glasses.
I think we're going to take one more question over here.
Well, let's just say more.
First name.
My name is Bruce Graff. I'm a general contractor. I'm a CATCH certified contractor. Many of y'all are aware of CATCH, certified aging in place specialist.
Yes.
So what we were trained to do, what we're doing, and a lot of this gets what we're talking about the mom, we will redesign, rebuild, remodel the bathroom so that it does not look like the hospital designed it. It's all really designer features. They look fabulous. We do curved showers. The towel bars, we have these really great looking towel bars that are actually safety bars. They're bolted into the wall, they're not going anywhere. And to your point that your mom couldn't see, got up in the dark and all this, we've done We've lighted murals and things in the bathroom and put spotlights on them, but we've put motion sensors so that if they got it in the middle of the night, that would come on dimly lit on that mural so that it looked really nice, but they could see in the bathroom. There's a lot of great things we can do now that we're aware of the issues. And then the house is more marketable. You can sell it to anybody. Again, it doesn't look bad. You can sell it because of how great it looks.
Great, thank you so much.
Laura, I have a comment.
Oh, and
I'm concerned about your footrest.
Thank you very much. I will not leave on that. I will just,
We're actually not going to have a private.
yeah, we don't want. I should agree up to this point. We're going to take one more question or comment about my chair. Go ahead.
Hey, I have a question in terms of children and how they can and when they should prepare with their parents to make these decisions about long-term care when they get older.
Now.
Great question.
Now.
I feel like Dr. has said
Yes,
now. Cheryl, how do you suggest people start that conversation? Because it's a very delicate, it's one that touches on family dynamics and lots of other issues as well.
Family dynamics, yes. Lovely, let's put the fun back in dysfunctional. It is a very difficult question to ask, but a lot of times if you approach it from the standpoint, mom or dad, we would like to do what you want to do, so what would happen if, it's not about aging or getting old, what if you were in an accident? We need to understand what your wishes would be, what medicines you're on, who are your treating physicians, what your medical conditions are, because if you can't talk to somebody, we need to understand that. And that brings forth the medical power of attorney. That also brings forth, what would happen if you got really, really sick or injured and you couldn't return home? Or, what would you like us to do? So it's more about how can we help you follow your wishes and desires. It's not about us taking control. It's about leaving the control with the decision makers, your parents, and approaching it from that standpoint, because it's almost as bad as saying it's time to stop driving. That's a whole other seminar. But the thing is, if you start approaching it from the standpoint, we want to honor you and your wishes and what you would like to do, and play that, what I call the what-if game, because people don't think about it. I've had people say, well, I'm fine, I'm healthy. You're 90 and using a walker. No, you're not that healthy. You're on 10 medicines, you've got high cholesterol, you can't see. No. And, I'm going to live forever. No. So people have this sense of immortality, and it's so skewed, so they really don't plan for that moment when something happens. Again, they all go, well, I'm just going to fall over and die. And a gentleman, this guy who said that he already had a couple of strokes, he was morbidly obese, was diagnosed as diabetic, hypertension, high cholesterol, and you name it. I said, no, we'll save you. So you need to make a plan. So again, it's about control, because parents don't want to give up control of the kids. But if they understand, hopefully, that they're keeping control by telling people what they want. But yeah, and if you've got parents that are 60 and above, 65 and above,
now is a good time. And I want to pass on for some closing remarks. If you have further questions or comments, still please send me a tweet or hashtag, and I'll try and get that answered as well to Doug from Baylor, who's going to give some closing remarks.
Well, thank you very much. It's always an honor to have the opportunity to host these types of events, and really on behalf of Baylor Scott & White and Baylor University Medical Center here in Dallas, and on behalf of Dr. Alan Jones and myself, I'd like to thank you all for allowing us to host this evening. Our vision is to be the most trusted place to get and receive safe, quality, compassionate care, and that vision is surrounded by a team of people that work every single day to care for people who come in our ER and who care very deeply about the work that they do. And these are not jobs that we have. This is a calling for us. And we're so proud of Dr. Jones and the fact that he takes the time away from his family to come and educate all of us about something as important as hip fractures. It's very special for us, and we take a lot of pride in that. So thank you, Dr. Jones, for being here with us. I'd like to say a special word of thanks to KERA News and Lauren for shining a spotlight on this topic, and one that affects so many of our patients and their families, and also those that shared their stories with us tonight. We're truly honored to be invited to be part of this conversation. One last thank you goes to the members of the IACT Summit for Innovation in Aging, Caregiving, and Technology. We appreciate all of your coming this evening, and I hope that you enjoyed the rest of your night. Thank you very much.